Hi, everyone. Welcome to our weekly webinar this morning. My name is Steve Caselli. I'm the director of the International Cardio-Oncology Society. We're happy to welcome you to this fourth installment in our series titled Cardiac Amyloidosis, a Zebra or a Horse. And as usual, we want to say thank you to our sponsors, AstraZeneca, Bristol Myers Squibb, Pfizer, for their support for this series. And we have three presenters today, Drs. Chang, Wacheliker, and Lenahan. And so I first want to introduce Dr. Richard Chang. Thank you, Richard, for being with us.
Good morning, everyone, and welcome. I have the privilege today on giving you a talk on the treatment of TTR amyloidosis as part of this series. This is part 4.4 for cardiac amyloidosis. Is it a zebra or a horse? My name is Richard Chang. I'm here at the University of Washington, Seattle. I'm a heart failure cardiologist and a cardio-oncologist, and I see many other patients with amyloidosis, both light chain as well as TTR in this region. These are my disclosures. There's clinical trial research funding paid to institution, but not to myself. As you know, there's been an emergence and evolution of treatment for cardiac over the last decade. This slide provides a nice framework for the various treatments. For the purpose of my talk, I'm really going to focus on the far right here, which is highlighted in red. So this is going to be for TTR-specific treatments. My colleagues, Ashutosh, is going to talk about treatment for light chain amyloid, and then Lenahan is going to talk about management of cardiac involvement with heart failure therapies, as well as management of arrhythmias. So I think in order to really understand the targets of therapy for TTR, it's really important to understand the underlying pathophysiology and the pathway in which TTR makes amyloid. So this is a simplified approach to this, but essentially the liver will make the TTR tetramer, which can then dissociate from monomers, which then misfolds to create amyloid fibrils, and this deposits in various organs, such as the heart, causing cardiomyopathy, as well as tendons causing neuropathy. So there's two proven strategies which are effective in treating TTR amyloidosis. First, we can lead to suppression of TTR synthesis. Historically, liver transplant was a good option for this in patients with variant TTR and polyneuropathy. Currently, FDA-approved treatments includes patisiran and inotersen for TTR variant polyneuropathy. And there's a lot of excitement about CRISPR-Cas9, for which a pilot study was recently published. Additionally, what's also proven is Tetramer Stabilization is very effective in patients with TTR cardiomyopathy. So for this, we have the FDA-approved tafamidis, for which many of you are familiar with. An emerging therapy is with AG10 with acoramidis. This is currently in clinical trials. And some centers use diflunisal as an off-label use, which is a non-selective TTR stabilizer. So these two strategies have been proven to be effective for TTR, polyneuropathy and cardiomyopathy respectively. Additionally, there are other strategies which may be effective, but we have very limited data, and these are currently in trial, so we don't know how effective they are or whether they're effective at all. This includes agents which lead to extraction as well as degradation of amyloid. So the question is, after you deposit amyloid in tissues, can you remove them? So that's really the approach here, and we don't have good data on this. For patients who develop significant cardiac involvements, we then move on to the realm of traditional heart failure therapies, which there's limited data on this. There may be some benefits, but we're not sure how much benefits. We do know that heart transplant can be offered to patients with end-stage disease. So I'm going to start by talking a little bit about stabilizers. The reason why I'm starting here is most cardiologists are very familiar with this therapy for TTR cardiomyopathy because it's FDA approved. And being a cardiologist myself, this is really one of my focus areas. So as we know, the tetramer for TTR typically transports thyroxine as well as vitamin A. What tafamidis does is it binds to the TTR at the T4 binding site, leading to stabilization. What you want to do is you want to prevent this tetramer from dissociating into monomers. By doing so, you can prevent the rate-limiting step of formation of amyloid. I mentioned earlier some centers use diflunisal. So this is an NSAID, which has been repurposed at some centers for use in patients with TTR amyloid. This also binds at the T4 binding site, but is less selective. AG10 is the evolving therapy. Essentially, this mimics structural stabilizing properties of a TTR variant that increases the tetramer stability. at least in vitro, it binds more selectively to the serum TTR than tafamidis and has higher kinetic stabilization. But we don't know how effective it is clinically yet, as this remains in trials. With tafamidis, this has been proven to be effective in the ATTRACT study. So I'm going to touch on this briefly because I think it's important to understand background. So this study was unique in that the primary analysis was done using the Finkelstein-Schultz method. So this is a non-parametric method which weights the various endpoints to increase clinical trial efficiency. Patients in this study were randomized 2:1:2 to tafamidis 80 milligrams, 20 milligrams versus placebo with follow-up of 30 months. The dosing of tafamidis 80 milligrams is bioequivalent to the currently commercial Venomax 61 milligrams. In this study, what they found is patients who received tafamidis had a 30% relative reduction in all-cause mortality. So market benefit. Additionally, there was a decrease in hospitalization, improvement in 6-minute walk, improvement in quality of life as measured by the KCCQ, and a decrease in BNP. So all very good things. They looked at various subgroups also, including the genotype, in other words, variant TTR versus wild-type TTR, NYHA functional class, as well as dosing of tafamidis. What they found is that the benefit was consistent across the subgroups for all-cause mortality. What about cardiovascular hospitalization? Here, this was mostly consistent, but what they found is patients with NYHA functional class 3 heart failure appear to have increased hospitalization. We do not think tafamidis increases hospitalization. Instead, we think that tafamidis likely leads to stabilization, longer survival in patients with severe disease, and because they live longer, they are able to unfortunately suffer hospitalizations. So this highlights and underscores a point that early detection is critical because we want to treat these patients early to result in better outcomes. A subsequent post-hoc analysis further stratified the ATTRACT data into patients with wild-type TTR versus variant TTR. So 2 lines on the top, the blue and red line, are patients with wild-type TTR. The bottom line is the black and purple, are patients with variant TTR. What they showed is that regardless of wild-type or variant TTR, the hazard ratio was consistent and the signal of benefit was consistent across these subgroups. However, for patients with wild-type TTR, there was separation of the curves earlier than for variant TTR, so the benefit from tafamidis appeared to occur earlier. Additionally, what they showed is that from a functional capacity standpoint, tafamidis also prevented decline in functional capacity as measured by 6-minute walk in both wild-type and variant patients. What about AG10s? So this is currently in trials, but this is data from the phase 2 open label extension that Dan Judge presented at AHA in 2019. So for this data, they compared the event rates with AG10 compared to historical controls for the placebo arm from ATTRACT. There was not direct comparison to placebo arm for this phase 2 study. But what they showed is compared to a placebo arm from the ATTRACT study, AG10 appeared to have lower rates for transplant or mortality. In addition, there were lower rates for cardiovascular hospitalization. So this is currently in phase 3 trials. It's done accruing and is in the follow-up phase, so hopefully there will be a readout for the study soon. So we talked a bit about TTR stabilization. In general, I think the thing to keep in mind is these therapies are oral and they're very well tolerated with very few side effects. So very easy to administer. Patients like it just because of the very few side effects. It's very well tolerated. I'm going to move on and talk about suppression of TTR production or knockdown next. So now we're really targeting the level of the liver to decrease TTR production. So this is how your body normally makes mRNA on the far left. So whether you have a wild type or mutant TTR gene, this is transcribed to mRNA, which then is available for translation. So in the middle here, we have inotersen. On the far right, we have pertuserin. The mechanism of action are slightly different, which I'm not going to go into in detail, but either of these essentially result in mRNA degradation. And by doing so, the mRNA available for translation is greatly reduced. As a result, TTR production is significantly reduced. And if you can't produce TTR, the idea is you can't really dissociate the TTR and you'll have less amyloid downstream. So with inotersen, this was studied in a neuro TTR trial. Inotersen is an antisense oligonucleotide. This was a study looking at patients with variant TTR polyneuropathy. And what they showed is that patients on inotersen compared to placebo had preserved neurologic function as measured by NIS. As you can see on the bottom here, patients on inotersen had less of an increase in NIS, so they had less neurologic symptoms over time compared to placebo. In the study, there was a small instance of glomerulonephritis or thrombocytopenia. So when these are used clinically, patients need to be monitored with urinalysis as well as their platelet counts. You might ask, what about for cardiomyopathy? So there was a single study looking at inotersen 33 patients with TTR cardiomyopathy, open label protocol. And what they showed is for patients on inotersen, there was a decrease in LV wall thickness over time and improvement in exercise tolerance. However, inotersen is no longer being studied in cardiomyopathy due to the availability of second-generation antisense oligonucleotides, which are currently in trials, which may be more targeted with fewer side effects. What about patisiran? So patisiran was studied in the Apollo trial. Patisiran is a small interfering RNA, similar to inotersen in this study. This was patients with variant TTR polyneuropathy were in the study. In the study, they showed that there was preserved neurologic function, again shown on the bottom, with the NIS scale on the y-axis. Essentially, patients on patisiran have preserved NIS and possibly some regression, so they might have had some neurologic improvements, not only stabilization. For patisiran, this was an infusion, and there was a potential for reaction to lipid nanoparticles. So patients who get patisiran need pre-medication, typically with steroids, to prevent the infusion reaction. In the Apollo trial, there was a cardiac subpopulation which was pre-specified with LV wall thickness greater than 13 millimeters. For these patients on patisiran over time, there's a decrease in wall thickness, preserved LS, and a reduction in NT-proBNP. Additionally, in the subgroup, there was a reduction in cardiovascular remission and all-cause mortality. So some signal of benefits. Keep in mind that in the parent trial, it was really in patients with variant TTR polyneuropathy, but the subpopulation shows that patisiran may potentially benefit patients with cardiomyopathy. However, both inotersen and patisiran are only FDA approved for patients with variant TTR polyneuropathy. What are the current trials with RNA suppression? So patisiran is being studied in a cardiomyopathy cohort in Apollo B. Additionally, a second generation patisiran called vutrisiran is being studied in Helios B in a cardiomyopathy cohort. Inotersen is not being studied in a cardiomyopathy population, but the second generation of inotersen, which is an antisense oligonucleotide conjugated to GalNAc backbone, is essentially being studied in CardioTransform. So these second generation agents are believed to be more potent and more targeted than the equivalent first generation agents. So now we're going to talk a little bit about CRISPR. So in order to understand CRISPR, I think it's important to understand why TTR amyloid is such an attractive target. So current TTR suppression or knockdown is based on the degradation of TTR mRNA. However, this is limited by the need for ongoing repetitive administration of therapies. So both inotersen and patisiran, as well as the second generation agents, you have to give these sequentially to patients. So they really, it's not a single administration, unlike CRISPR. Additionally, there are potential for side effects over time, which I touched on briefly. With CRISPR, this is an in vivo gene editing with single guide RNA. The reason why TTR is so attractive is it's a monogenic disease, so it's theoretically easier to target. Additionally, TTR knockdown has limited additional physiologic effects. So the TTR, there's some redundancy, and even if you knock it down significantly, patients seem to do okay. TTR is mostly made in the liver. For this reason, you can target it with lipid nanoparticles. So this is the mechanism of CRISPR-Cas9. So in the pivotal study from Dr. Gilmore and colleagues at the United Kingdom National Amyloid Center, they did this in 6 patients. 3 received 0.1 milligrams per kilogram and 3 received 0.3 milligrams per kilogram. I really encourage you to look at the video on the New England Journal of Medicine websites because they can explain it much better than I can. But essentially for this, there is an NTLA 2001 lipid nanoparticle delivery system with liver tropism. This targets the liver and delivers messenger RNA with a Cas9 protein and a single guide RNA that contains a TTR gene-specific sequence. Essentially, this compound's uptaken by the hepatocytes, and this leads to downstream sequence-specific cleavage of the TTR gene, resulting in a frame shift mutation that prevents production of functional TTR. In this pilot study, treatment was completed in all 6 patients. There were grade 1 reactions and no significant adverse events. So as you can see from the top graph, which is the patients receiving 0.1 milligrams per kilogram, the bottom are patients 0.3 milligrams per gram. At 28 days, there was significant reduction in TTR serum concentration. For those receiving 0.1 milligrams per kilogram, there was a 52% reduction in serum TTR. And for those who received 0.3 milligrams per gram, there was 87% reduction at 28 days. So very promising. My thoughts on this are that the benefits are that CRISPR-Cas9 is a single infusion, which results in permanent silencing theoretically. So patients are excited because there's a lot of implications for adherence, right? I mean, the idea is patients receive a single dose and that's it. They don't have to keep injecting themselves or repeatedly getting infusions. There may be cost implications because this is a single dose. Over time, it may end up being cost effective, but we don't yet know how much this will cost, and we don't even know if it's going to make it to market commercially. Limitations for the early pilot study is this is a very small N of 6 patients. The early data has limited follow-up time, so we don't know the long-term efficacy or potential side effects. There are some potential concerns for genotoxicity or of oncogenic side effects. Although preclinical data showed that the approach was precise, at least in this pilot study, appeared to be safe. But however, I think we really need longer-term follow-up to understand the long-term efficacy as well as potential for side effects. So now that we've talked about CRISPR, I'm going to move on and talk about amyloid degradation extractors. As I mentioned earlier, these are not proven therapies. These are in trials, and we don't know how effective they're going to be. So for amyloid degraders and extractors, there's quite a few which are being developed. PRX004 is a monoclonal antibody that binds to misfolded TTR and clears amyloid deposits. This completed a recent phase 1 study in which it appeared to be safe and well tolerated, and there was modest improvements in global longitudinal strain. However, I think additional data is necessary before this is going to become available or whether it's become available. NIX006 is a recombinant monoclonal antibody. It's in a phase 1 study and is currently enrolling. There was a lot of interest in the anti-serum amyloid P monoclonal antibody. However, in a phase 2 study, this failed to show improvements in amyloid burden, so it's no longer being developed. What about all the other stuff? So patients will frequently ask you about supplements. So this was a recent systematic literature review, which was published in the Journal of the American Heart Association in 2020. They looked at various other compounds, and in effect, they felt that there isn't enough evidence to support use of these other compounds. This includes doxycycline, which is often administered with TUDCA, which is believed to disrupt TTR fibrils, but data is very limited. There is also EGCG, or green tea extract, which is believed to inhibit amyloid fibril formation. But again, data is very limited, and we don't use this regularly in clinical practice. There's some data for curcumin or turmeric, which may have protective effects by stabilizing TTR, but data is again very limited, and this has a very short half-life, and very high doses are likely necessary. So in other words, these supplements, I don't think there's enough data to really support the regular systematic use in clinical practice. So what is currently available? This is a slide made by Dr. Rick Rubrick back in 2019, and it hasn't changed very much to the current contemporary era. So for patients with wild-type TTR cardiomyopathy, we have tafamidis, which is an FDA-approved stabilizer. You could potentially use diflunisal, which is a TTR stabilizer, as off-label use. For patients with variant TTR with cardiomyopathy, the treatment is with tafamidis or diflunisal. For patients with variant TTR polyneuropathy, you also have RNA suppressing agents with patisiran or inotersen, whether they have a mixed phenotype or neuropathy alone. And hopefully this will change in the future as more of these clinical trials are completed, and hopefully some of them will be effective. So take-home points for TTR treatments, there are 2 main strategies proven to be effective for treating TTR amyloidosis. Number 1, we can suppress production of TTR with patisiran and inotersen, which are FDA approved for variant TTR polyneuropathy. Or we can stabilize TTR protein in patients with TTR cardiomyopathy with tafamidis. CRISPR-Cas9 is very promising with the pilot data, but I think we really need long-term follow-up and a larger N before we really know how effective this is going to be or how safe this is going to be. There are also emerging therapies for degraders and extractors, but the data is very limited.
It is my pleasure to join this symposium today to talk about novel treatments for AL amyloidosis. As you realize, amyloid pathway is quite a complex process, starting with misfolding of the light chains, binding to various glycosaminoglycans, forming of the oligomers, and then amyloid fibrils. In theory, one can target the amyloidogenic potential anywhere along the pathway. We have antibodies, which could be directed at glycosaminoglycans. We've got antibodies which could be directed to the fibrils, which will help us in clearing amyloid deposits. We could have drugs which can help with the misfolding. And then, of course, we have treatments which will kill the plasma cells. Thus far, our mainstay of treating patients with AL amyloidosis, but something that is evolving at an extremely rapid pace. Why do we need new treatments? We have got a number of treatments over the years. Our challenge in amyloidosis is that organ responses tend to be slow. Deep and complete responses are only seen in a third of patients. Patients with cardiac amyloidosis, particularly those with advanced stage disease, we still see between 40 and 50% deaths by year from diagnosis. And the same is true of renal patients. Patients who present with advanced stage renal disease, maybe half to two-thirds of these patients will end up on dialysis, which, whilst not particularly being a cause of mortality, is a significant cause of morbidity and cost to a patient. We have made a lot of progress over the years. The median survival of AL was about 1.5 years, which really didn't change until the early part of last decade. With new therapies, we were able to show that the median estimated survival by 2012 had reached nearly 4 years. And in our contemporary cohorts, we are now seeing median survivals routinely exceeding 5 years for all patients, and almost 90% in patients with stage 1 disease, that is the ones who don't have cardiac involvement, and nearly 70 to 80% in those with stage 2 disease, those with early cardiac involvement. The treatment for AL amyloidosis has evolved, as have the treatments for multiple myeloma over the last few years. And all of these drugs have been licensed for treatment of myeloma, and they have been, one way or the other, adopted for treatment of amyloidosis with dose modifications based on small phase 2 studies or a number of retrospective clinical data. But 2021 was a very important year. We had DARA VCD licensed for treatment of AL amyloidosis. You have all heard of this clinical trial, and we'll talk a little bit more about it in the coming slides. From our perspective, the treatment for AL is risk adapted. About 1/5 of the patients have low risk disease who would be potential candidates for an autologous stem cell transplant. We then have patients with very high risk disease, those with high risk of death, those with very advanced cardiac damage, those with coagulopathy, low blood pressure, poor performance status, worsening heart failure symptoms. And these are patients where we really haven't made a huge impact on outcomes. And then most of the patients fall into these intermediate disease categories. And we have newer risk factors such as bone marrow plasma cell percentage, cytogenetics, and then some more things coming in about global longitudinal strain, and 6-minute walk test, all of which allow us to risk stratify the patients for treatment a lot better. We have recently published some data which is quite critical to how we judge the treatment for our patients. What we were able to show was that patients with AL amyloidosis who achieve a complete response or a very good partial response, which is light chains dropping to under 40 milligrams per liter DFLC, their survival is substantially better than those who get a PR or don't respond by 1 month. And this is true across all disease stages. I'm just showing you an illustrative graphs for those patients who present with Mayo stage 3 disease. And you can see that there's a significant improvement in survival for the stage 3 patients compared to those who don't get a response in 1 month. So rapid responses are now becoming really crucial for us to decide how we change treatments. And certainly our algorithms in the UK are now following what we have published. We would certainly believe that if we don't get a good response to treatment early in AL, we would switch to second-line treatment very quickly. And patients who don't get a deep response to treatment, such as a complete response or very low light chains, which have all been associated with good outcomes, and particularly cardiac patients who don't get a complete response, we will switch therapies. One of the questions which keeps cropping up for hematologists treating amyloidosis is what is the role of stem cell transplantation in patients with AL amyloidosis with low-risk disease? We recently compared our outcomes in a matched series of about 68 patients with AL who had either VCD, CyBO-D upfront or stem cell transplant, and we were unable to show any significant benefit of transplantation in survival. When we looked at the depth of response, again, there was no substantial difference, although maybe there was a hint that patients with stem cell transplant who got a CR had slightly better time to disease progression. So this remains questionable. Transplantation has been done in the same way, and we've recently completed our phase 1 clinical trial looking at transplantation with radiation-based conditioning. And based on this trial, we gave radiation on day -22, no chemotherapy, and then the patients were transplanted on day 0. And this was a very well-tolerated treatment, and patients did not have all the usual complications of transplant, such as mucositis, fevers, diarrhea, abdominal pain. Their nutrition remained very good. And even with this phase 1 study, we were able to show that 6 out of the 9 patients treated had achieved a reasonable response. We are hoping that we'll move forward with a phase 2 clinical trial in this setting. Daratumumab, which is an anti-CD38 monoclonal antibody, which has now been licensed for treatment of myeloma, both for upfront and relapsed refractory setting, has also been studied in AL amyloidosis. The pivotal study was the Andromeda clinical trial, where patients were randomized to Dara-CyBO-D versus CyBO-D, and you have probably heard of this elsewhere in Talks on AL, showing a substantial superiority of Dara-CyBO-D over CyBO-D in achieving complete response, 53% complete response rates in the Dara-CyBO-D arm, compared to 18% response rates in the CyBO-D arm. This also translated into a longer time to what was defined as modified PFS, MOD PFS, which was heme progression, end-stage heart or renal progression or death, much greater in the CyBO-D arm, better in the Dara-CyBO-D arm. This, of course, has led to this being licensed across most of the countries around the globe. Patients with AL amyloidosis will inevitably relapse after initial therapy. What we were able to show recently was that patients who relapse following initial treatment behave very differently from what is our experience with other blood cancers. The depth of response seen with second line, third line, and fourth line treatment appear to be very similar, whereas in other malignant conditions, we find that these depth of responses appear to drop off quite substantially. But one thing was rather surprising for us. The survival from the start of every single line of treatment appears to be very similar, which essentially means that once the patient has relapsed, they will revert back to the initial stage and we still see mortality. May not be as dramatic as the stage 3B disease, but we still see mortality, which means that our patients have progressed and we need to consider treating them early. One of the most important agents for relapse disease, particularly for patients who have not received upfront daratumumab, is now daratumumab, either as single agent or in combination. We see very deep responses, CRs of EGPRs in 70 to 90% of the patients, depending on which particular study we look at, translating into good organ responses. Ixazimib is an oral proteasome inhibitor, which has now completed a phase 3 clinical trial. The primary endpoint of the trial was hematologic response rates, and this endpoint appeared to be negative with no significant benefit of Ixazimib compared to physician's choice. But what was quite striking was that the duration of response for patients with Ixazimib was nearly twice that of patients treated with physician's choice, which translated into a much longer time to treatment failure or subsequent therapy in the Ixazimib arm compared to the control arm. We certainly feel that this drug has a role in treating patients with AL amyloidosis, especially those who have not been treated with a proteasome inhibitor up front. 50% of patients with AL have this specific chromosomal translocation T1114. And there's a drug called Venetoclax, which targets this particular translocation, blocking cyclin D1. A number of studies have now been reported, 2 retrospective trials, one from the Mayo Clinic and one an international collaborative study, essentially showing deep responses, 78% CR of EGPR, 41% complete responses in multiply refractory patients with AL amyloidosis treated with this agent, and appears to be reasonably well tolerated. We hope to see some prospective studies in the coming years. But the key really in AL is to eliminate the light chains. We have had a number of monoclonal antibodies which can target these amyloid deposits. A couple of programs, anti-SAP NEO-001, were completed and maybe restarted in some cases. We have got the KEL-101, which is ongoing, and there are others which we may see coming along the line. One of the new anti-plasma cell treatments is a BCMA, B-cell maturation antigen-directed monoclonal, conjugated with a toxin called belantamab or belamaf. And this is being studied in a phase 2 clinical trial in Europe, and hopefully a similar trial in the US. We have treated some patients with this where we had access to the drug, and we can show this was one of our first patients showing rapid responses, and the drug appears to be reasonably well tolerated. One of the major things in AL amyloidosis is to clear the amyloid deposits, and if we can accelerate the clearance, this video was meant to play, accelerate the clearance of these deposits, we could certainly see rapid improvement of organ function. We have had 3 phase 1 clinical trials. One was with our anti-SAP program, one with KL-101, one with NEO-001, and then we had 2 phase 3 clinical trials with the NEO-001 program. The NEO-001 trial, the VITAL study, which looked at NEO-D001 compared to standard of care, was closed early because of potentially considered to be futile, was unable to show a significant superiority of NEO-001 over placebo. But when a post-hoc analysis was done, it was very apparent that patients with stage 4 disease had a significantly superior outcome in the NEO arm compared to the placebo arm. This has now gone on to a new phase 3 clinical trial, which should be opening in many centers around the globe. And certainly if you have patients with newly diagnosed AL amyloidosis, please do consider them for clinical trials. KEL-101 is another antifibril antibody. This was a phase 1 study report, which was recently published in Blood, showing that patients who received a single dose of this monoclonal showed a significant cardiac response in nearly 67% of the patients, often quite rapid, and about a third of the patients showed renal response. And what was more important was patients who had progressed following this treatment still did not show evidence of any end organ progression. We have 2 phase 3 clinical trials which are running in patients with advanced cardiac amyloidosis for patients with Mayo stage 3A and Mayo stage 3B disease. This is the first antibody to be studied in patients with stage 3B. In fact, this is the very first prospective clinical trial of any drug in stage 3B disease. With this antibody, they were able to track the 2D strain, and there appeared to be a substantial improvement in the global longitudinal strain at 12 weeks following treatment. When we track patients who are treated with standard chemotherapy, the only time we really see such significant improvement in global strain is about 1 year to 2 years following treatment. And again, then only in patients who have achieved a true complete response to therapy. There are 2 phase 3 trials, as I said before. And again, if you have patients with newly diagnosed AL, please do consider them for these 2 clinical trials. To conclude, AL is not as uncommon as we thought. One of the things which I did not mention in this talk, but which is increasingly crucial, is that we need to differentiate AL and wild-type ATTR better because treatments can be very different. We need to incorporate functional markers to risk stratify and allow us to select patients better for treatment. We have got a number of new anti-plasma cell therapies, which has clearly improved the outcome for AL patients. Dara-Cibodi is now licensed for AL. In the UK, we're still awaiting approval. There are other monoclonals which show promise. Venetoclax is a very attractive agent for AL with T1114 translocation. Antifibril antibodies are tantalizing. 2 early trials have not shown any evidence of response. 3 phase 3 clinical trials are running at the moment, but we look forward to the results, but remain to be proven, but we hope that we'll see some positive results. One thing is for certain, early diagnosis remains problematic as ever. I know this is a talk on new treatments, but if we don't diagnose early, patients have advanced organ damage, we really can't make a difference. And therefore, we have to think about amyloidosis. And my final message really is, think amyloid. It is not as uncommon as you think. Finally, I'd like to thank all my colleagues at the National Amyloidosis Center at the Royal Free Hospital, and also our amyloid myeloma treatment team at University College Hospital. Thank you.
Thank you again. This is Daniel Lenahan, immediate past president of the International Cardio-Oncology Society, and I'm going to talk about putting it all together. You've just had 2 great presentations, one from Dr. Chang on predominantly the treatment of ATTR, and then you had an excellent presentation by Dr. Weschelacker on the treatment of AL. And so now I'm just going to pull those two issues together, and how do we actually treat especially cardiac amyloidosis? So the first basic principle is that I'm not going to talk about the treatment of the specific type of amyloidosis, because that was just presented. What I'm going to talk about is how do we manage the cardiovascular problems that occur in either one of those types of amyloidosis. So the first and foremost, most important thing really is, because most of these patients with cardiac amyloidosis have a significant diuretic need, this is really our mainstay. And many people and many doctors that are managing these patients will use a combination of diuretics. But in addition, salt restriction is really essential. Frequently, these patients have large amounts of peripheral edema or ascites, and this is made worse by hypoalbuminemia. If they have AL, for example, and they have nephrotic syndrome, their albumin may be particularly low. And then when you talk about management of heart failure, of course, historically we've used digoxin, and then more recently, beta blockers, especially carvedilol and others, are mainstays in the treatment of systolic heart failure. These drugs are not well tolerated in patients with amyloidosis typically. And then, of course, calcium channel blockers really are not well tolerated in heart failure in general, and then especially in patients with amyloidosis as a cause of their heart failure. There may be a select instances where you would try vasodilators such as ACE inhibitors or angiotensin receptor blockers. And that would be in a case where they have nephrotic syndrome and perhaps they may have temporary hypertension. But to help manage the proteinuria, these drugs may be very important. However, it can be very difficult to get the right dose for an individual patient because of hypotensive responses. And then the whole how do you manage hypotension in these patients is a very tricky issue. And it's quite frequent that you may need to use midodrine or droxidopa, which are helpful for orthostatic hypotension or autonomic dysfunction, which is a common condition in these patients. And then the treatment of atrial and ventricular arrhythmias is a very complex topic. We don't have enough time in this presentation to go through it in great detail, but I would say that interaction with our electrophysiology colleagues is really essential in these patients. So I did want to talk a little bit about the treatment of autonomic dysfunction in cardiac amyloidosis in particular, because it is a very challenging situation. Your typical treatment for heart failure is not tolerated, and you got to figure out a way to keep the patient from being highly symptomatic from hypotension. So as mentioned earlier, midodrine and droxidopa, as listed on this table, are probably your top two medications. And in people with severe autonomic dysfunction, I may reach for both of those medicines simultaneously. So the downside is that you can get some supine hypertension and then also tachycardia depending on the doses that you're having to give. Other drugs that are used for autonomic dysfunction, for the most part, I don't really use them very often, and I don't really feel like they're very helpful in patients with amyloidosis. This includes Florinef, which would definitely lead to sodium retention and worsening volume status. And so I usually do not use Florinef in these patients. And one interesting drug that is used in the heart failure world is ivabradine. And technically speaking, ivabradine has been studied in a prospective randomized study looking at patients with POTS syndrome, to show that it could help with the sinus tachycardia and the autonomic dysfunction. So I actually have occasions been able to use ivabradine in support of patients with amyloidosis. The one requirement there is that they maintain sinus rhythm. And then there are, of course, non-pharmacologic treatments for autonomic dysfunction, which really should be applied in every patient, especially if their symptoms are significant. And those are highlighted here. When we talk about arrhythmias, it is a very complex topic, especially in patients with cardiac amyloidosis. So the things to emphasize that atrial fibrillation is a very common condition and more common in these patients than in the general population. It also may be difficult to control their heart rate because they don't tolerate beta blockers and calcium channel blockers that have significant rate control. So this is a challenging problem. There is a lot of controversy about when do you place an ICD for the prevention of sudden death. And a lot of that is based on the fact that the ICD may not be all that effective in those patients because of infiltration, and also because you don't fully understand the expected outcome of patients with amyloidosis. So this is an area that you definitely have to personalize your decisions. And then the really important part that absolutely should be emphasized in patients with amyloidosis is that the high rate of intracardiac thrombus and the risk of stroke. So if you are seeing a patient that developed atrial fibrillation, and even if you put them on appropriate anticoagulation and you're thinking, well, I'm going to do a cardioversion, I would say at this point, because of some recent studies, it's essential that you do a transesophageal echo to exclude the presence of an atrial thrombus before you do a cardioversion. And there's a very high rate of persistent thrombus in patients with cardiac amyloidosis. So this is a very difficult area and one in which we're trying to define best practice at this point. So then how can we actually help educate our patients? Because, you know, especially if you're talking to the patient directly, they have never even really heard of amyloidosis, and because the literature that they may find may be dated, it's actually very difficult to explain all the complexities of amyloidosis to our patients and their families. So what are the things that we can really do to improve their understanding? So you really need to explain what the symptoms of heart failure are. And for this sophisticated crowd, I'm not going to go through all of these things, but I do think that especially for our patients, it's really important to explain what heart failure is and how it is present in amyloidosis and what things do they need to monitor to maintain stability. And some of the simple things are assessing their fluid status. So you need to try to educate the patients so that they know whether or not they're retaining fluid. And you think that's a simple thing, but it actually is not. And you know, many of these practical details get pushed to the side because of other major issues that you have to discuss. But nonetheless, ankle swelling, abdominal swelling, orthopnea, PND, and weight gain are all crucial in terms of determining fluid status. And then daily weights. If you can get your patient to weigh themselves every day, then that, to me, is a huge victory, because you're actually making the connection between a weight gain episode and your diuretic dosing and how much sodium they may have taken in. So I think this is a critical issue. And then in terms of exercise, you know, we really are firm believers in exercise as part of the management of any cardiac disease. And these are just some basic things that I always try to talk to patients about. You know, don't try to do a marathon at the beginning, and, you know, don't go exercise when it's 10 below, at least outside. And then, you know, if you do some sort of exercise and you don't feel good, then stop and get at it the next day or the day after, and don't be discouraged. Those are all critical elements. So in terms of putting it all together, absolutely careful attention is essential to know what the volume status is. And in patients, they need to understand that. And as providers, we obviously need to understand that. Sodium restriction is essential. Autonomic dysfunction is a common occurrence and really may present a lot of difficulties for management. Generally speaking, the typical medications used for heart failure are poorly tolerated, of course, with the exception of diuretics, which are really the mainstay of treatment. And then arrhythmia issues are complex and very common. It is particularly notable that the rate of atrial thrombus is unacceptably high and requires special consideration. And then, of course, as Dr. Chang and Weschelacker had presented, the specific treatment for AL and ATTR amyloidosis is absolutely critical to change the disease process. And this has really led to improved outcomes for these patients. So I'll stop there and look for our question and answer session to go through some of these details. So Dr. Chang, I know that you have seen at least one of the questions that's out there. I don't know if you want to take that one on.
Yeah, no, thank you, Dan, for that wonderful talk, and I'm happy to address this question. So we have a question from the audience. What criteria for choosing just one drug to treat one patient select among the three groups? Degraders, suppressors, or stabilizers, or is it one size fits all? And this comes from Agnesi Maria Ferretti Bari in Italy. So that's a very valid question. I think the first thing to keep in mind is that the degraders are not currently available. The initial studies with them have not proven effective. So the Calum drug is still ongoing, but it's being tested in light chain amyloid. And then for PRX drug, it's being tested in TTR, but it's barely entering phase 2. So we don't have data on it yet, and we don't know how effective it will be. So degraders are really not an option at this time unless you enter a patient in a trial. So essentially what we're left with are suppressors or stabilizers. In general, at least in the United States where I'm located, in terms of which we decide to prescribe, it depends on what the FDA indication is. So currently for patients with either wild-type TTR cardiomyopathy or hereditary cardiomyopathy only tafamidis is available, so they automatically get stabilizers. For patients with hereditary TTR neuropathy, then the silencers are available with either patisiran or inotersen. I think for patients with hereditary TTR with a mixed phenotype, so those patients who have a combination of neuropathy and cardiomyopathy, then your option may be a stabilizer or a silencer. For those patients, at least at our center, we tend to use more of a silencer. And in talking to other centers, I think that's a general trend because with, at least for the studies in neuropathy patients, there was some evidence of regression of disease where stabilizers, we think there probably is, it's a true stabilizer and there probably is not much regression.
Yeah, so that's really a great question from Dr. Fioretti. I think that, what you just said, Richard, is totally on the money. I think the one thing that at least I have felt from the patisiran data versus inotersen is that in the patisiran study with neuropathy, they actually showed an improvement at 9 and 18 months, whereas the inotersen data showed not an improvement, but not a worsening. So I think that there was some difference between those two drugs. And then, as you are, I know you're aware of this, that the particularly in Portugal and I think somewhat in Spain, but where they had tafamidis available for the neuropathy-related hereditary conditions, that tafamidis in those patients really didn't do that much, and it was more the silencers that had a bigger effect on the neuropathy. So I don't know if you agree with that or not.
Yeah, no, I completely agree with that. And I think that's the generally what we see. From a combination therapy standpoint, we don't have data on that, because I think that was the other question in terms of whether we would use combination treatment. Although there is going to be data, as you know, coming out from the ongoing trials with both the second generation drugs from both Alnylam as well as Ionis, in terms of these trials entering patients already on stabilizers. So we may see whether combination therapy is more effective, but we don't have, as far as I know, I have not seen any data on combination treatment, unless Dan, you've seen some data on that.
No, just like you said, in both the Apollo 2B and I think it's Transform TTR studies, in both of those studies, a percentage of the patients were on tafamidis already, and then they were a silencer was added in a randomized fashion. So there will be a subset of those patients that are on both drugs, and perhaps we'll be able to tell something that that the combination was particularly effective or not. I mean, I don't know that.
Yeah, I think the nice thing is, from a biological mechanistic standpoint, they should be synergistic. The idea is you would knock down a proportion of the liver production, and then you would be able to stabilize the rest. So theoretically, patients would do better on both, but I think it's very limited. I think the only other point I want to make in terms of these drugs is, in general, stabilizers tend to be better tolerated. Right now, they're oral, there's very minimal side effects, whereas the silencers, they're either injectables or infused, and there is some potential for side effects. So I think for some patients of mine who do have a hereditary mixed phenotype, if they can't come in for their infusions or injections, or the surveillance is too much for them, we tend to use stabilizers.
Yeah, great. You have another question there, but I'm going to take a question from Dr. Patricia Guerrero, who is in Orlando. She asked a zillion-dollar question here, because I don't really know the answer to that, but what is your optimal anticoagulation strategy in a patient on existing NOAC or DOAC, depending on what you call them, who develops a left atrial thrombus? So actually what I would say is that they probably already had the thrombus, and if you were on a factor 10A inhibitor or something like that, and the thrombus doesn't go away, what do you do about that? That seems to be the more common question for me. And so I have tried a number of different strategies, and I'm not sure that I know which one is better, because I can't really tell. So, for example, if a patient goes into atrial fibrillation and you want to do a cardioversion, and they have cardiac amyloidosis, you put them on your favorite anticoagulation, and in this day and age, I would probably pick a factor 10A inhibitor, first out. When you come to do the TEE and you see a persistent thrombus, you have several possible choices. You can continue the DOAC for a longer period of time. You can try to establish whether the patient was actually taking it or not, and that's always a really important question. And then of course, you could switch to something else. So if you said, well, I'm going to switch to Coumadin, which is probably not as effective, I have some people that have adopted that strategy. Others have tried to switch to something like Venomax or some other injectable low molecular weight heparin. And I think in that situation, you could make an argument that it might be better. But I've tried it in a number of patients, and I would say it may have worked once, it may not have worked. I'm not really sure. But the bottom line is that you can also entertain the possibility of putting a Watchman device in, but then you have to convince your Watchman implanter to put a Watchman in a situation where there's an existing thrombus. So it's a real complex story. Richard, I don't know what you would say about all that.
Yeah, I think that's a very tough situation, and unfortunately something that we sometimes see in these patients because they're so prone to forming thrombus. For us, we tend to switch to Coumadin if they're on a NOAC, and that persistent thrombus, and then we run the INR higher. There isn't good data on this. This is anecdotal. We've had some success doing that. We don't use much injectables just because it's inconvenient for the patient, but I guess that's a valid option also. And I can tell you, at least at our center, our providers are very reluctant to implant Watchman devices in patients with active thrombus, as you alluded to, because I think everyone's worried about embolizing it. Yeah.
Right, but I think that if you can convince your EP colleague or whoever your colleague is that does the Watchman, if you can convince them to do it, I have had two cases where they actually did it, and afterwards we saw no evidence of thrombus, and so that's a very individual anecdotal story, but I do think that I don't know what the right answer is, and I think do your best, whatever it is. There was another question for Dr. Chang from Mohammed Alamar in Tampa. Do you want to take that one on? Do you see it? It says, what is your experience with tafamidis insurance approval? Any helpful tips on the process? And then number 2, do you routinely get cardiac biopsies for an ATTR patient prior to starting tafamidis?
Great. Those are really clinically relevant questions, so thank you for them. I'm going to start with the second question just because I think it leads into the first question. But from a diagnostic perspective, the current algorithm doesn't recommend doing biopsies. So typically in any patient who has suspected to have amyloid, so for example, with red flag features, patients with HFpEF, LV wall thickening, carpal tunnel syndrome, spinal stenosis, AFib, as well as other parameters on echo, the first step is really excluding light chain amyloid in these patients if you're looking for TTR. So you have to send serum and urine fixation as well as free light chains. If those are completely normal, then you can confirm the diagnosis non-invasively with a nuclear prophosphate study. And there's quite a bit of literature on this showing that the sensitivity and specificity of this approach is very high. The times where we pursue intramural biopsies are when the light chains are equivocal or there's some concern for plasma cell dyscrasia. And those patients, we then proceed to intramural biopsy. Is that what you do, Dan?
Yeah, I mean, I'm a little bit more inclined to do a biopsy than it sounds like you are, but I also think that I don't know how often you've encountered this, but when you're seeing a patient and let's say they have all the historical and imaging features of TTR, and you do a serum-free light chains and they're moderately abnormal or mildly abnormal, and maybe or not you see some sort of monoclonal protein, and you could even see 2 peaks. So like I've had that happen frequently where there'll be 2 monoclonal peaks when you do either your serum or your urine immunoelectrophoresis. So then you're in this place where all the clinical features say TTR, but you still have a little question out there. And in that situation, I would always go to a biopsy. But I do think that if you do a serum-free light chains and immunoelectrophoresis and they're totally negative, then you're right. You can confirm the diagnosis by other means.
Great. Yeah, and then I think the second question is a very clinically relevant one. So once the diagnosis is confirmed, from an insurance approval standpoint, our experience has been pretty good. I would say in almost all instances, the insurance will approve it. I think the difficulty is what the copay for the patient is. So what often happen, at least for us, I think our experience has been almost every patient except for maybe 1 or 2 have gotten insurance approval. And then sometimes I've seen a copay, and I still don't understand this because I think this is very dependent on individual level circumstances. For example, there's specific insurance and their salaries, but I've seen anything from $0 up to several thousand a month. So for patients who have higher copays, then we go through the Venomax procedure, where it's a program run by Pfizer, and then essentially looking for foundation assistance. And a lot of my patients have been able to get tafamidis for almost nothing for the patients, although there is a lot of paperwork involved. And this is something that needs to be reapproved each year. I would say one caveat to that: early on, we were doing a lot of the paperwork ourselves. My heart failure nurse is very good at this. He spends a lot of time doing this. Over time, once we started prescribing quite a bit, we got our pharmacy to buy in. So now our pharmacy, or specialty pharmacy, handles almost all the paperwork for us. For the pharmacy, there is some degree of incentive. So you might, if you have enough patients, it's actually advantageous for your pharmacy to consider being a specialty pharmacy to prescribe this drug, because for them, they do get some type of reimbursement for this. And at least for us, they now handle all the paperwork for us.
Yeah, no, that's a beautiful point. And I know you felt the pain on the paperwork to get to that place. But yeah, if you can get pharmacy and especially specialty pharmacy support, that's really essential. There's another question from Dr. Guerrero, which is also very good, which it says the patient with AL cardiac amyloidosis status post BMT for myeloma that develops progression of amyloidosis. What is your next therapeutic strategy? I mean, that's a tough question, and probably Dr. Wetchelacker should answer it. But in my understanding, current, and I'm not a hematologist or oncologist, but right now, daratumumab-based therapy is really the best proven therapy at this point. And so, especially somebody who's had multiple myeloma before and probably seen a number of different therapies, including an autologous stem cell transplant, there's a lot of history there. So your decision for what to do going forward is going to be complex and it'll be individualized, but it will almost always involve daratumumab. So whether it's a single agent or in combination with some other agent is usually the way it goes, as far as I know. So Richard, I don't know if you have any other comments about that.
Yeah, no, I would say, my experience with this, being an advanced heart failure provider, we have a number of, it's a little bit different than what the question is asking, but we have a number of light chain amyloid patients who we've done heart transplants on, who then have progression of disease. So for those patients, it's exactly as Dan said, because daratumumab is so effective, oftentimes our hematologist oncologists will just leave them on daratumumab long term, and it tends to suppress their light chains.
Yeah, great. And then another excellent question from Dr. Fioretti. To evaluate and follow up the autonomic dysfunction, could we use the heart rate variability analysis by Holter monitoring in the frequency and the time domain? I mean, this is a great question, a detailed EP sort of question. I personally don't do that. I think that the difference between sinus rhythm and AFib is sort of the essential piece, because if a patient with amyloidosis has autonomic dysfunction and they're in AFib, then you're deep into the weeds there, and so you're probably going to have some trouble with rate control, and then also you're going to have trouble with orthostatic hypotension. So these are complex decisions, and the range of choices is quite wide. As far as Holter monitoring, I don't use that really much anymore, and but I don't know, Richard, if you have a different thought on that.
No, I mean, I completely agree with those comments. So many of these patients end up with atrial fibrillation, where I think the heart rate variability is difficult to follow, and it's not something we've looked at because these patients tend to have relatively advanced disease, so we tend to treat their active issues. And but I think it is a very valid point, something I should probably be looked at.
Yeah. Great. So thank you so much. I think the questions have been excellent, and Dr. Chang, thank you so much for fielding some of them, and your presentation was outstanding. So we do want to leave the evaluation part as the last slide, so that you make sure you get your CME credits. And we really appreciate everybody's time and attention. And Dr. Chang, thank you for joining so early.
Great. Thank you, Dan. Thank you, everyone, for joining.
All
Have
right.
a great day.
All right. Thanks a lot.